Assalamualaikum. কেমন গেল last 2 days? কেমন গেল সবার? এত অল্প ভালো? এখনো অল্প ভালো? আচ্ছা, থ্যাংক ইউ। সবাই কি একটু টায়ার্ড? টায়ার্ড হলো আজকে আমাদের today's. Okay, thank you so much. Today is our learning session. First session is congenital femoral deficit by Professor Hitesh Shah. Please, I welcome you, Professor Hitesh Shah, for congenital femoral deficit.
Good evening, friends. Is it audible, loud and clear? Yesterday I was sorry. Okay, I'm going to discuss a few cases of the congenital femoral deficiency. It's actually the rare, it's not very common, and it's one of the very challenging problem for the parents as well as the pediatric orthopedic surgeon. I like to say that how many are actually treating PFFD or the congenital femoral deficiency? Can you raise the hand? Yes. Okay. So it is much more of the interactive. I'm not taking up lectures on the PFFD, but we will show and discuss few cases, and we'll say what has to be done for that. So we'll ask the senior guys who are actually having experience with the congenital femoral deficiency or the PFFD or DFFD. Can anybody say why the name has changed? CFD or the PFFD? Because it's people used to describe that PFFD, focal deficiency actually, that is proximal femur. Okay, so why it has been changed? Because it's a spectrum. When originally description say the congenital short femur is different, proximal deficiency is different, and distal deficiency is different. So when we combine all three together, we'll say the congenital femoral deficiency. Okay, it's easy on that. So directly we'll go on a case. This is a girl. This is a 2-year-old girl present with the 4 centimeter shortening on the femur. So what are the variables we should consider? Any classification do we use? What classification, and how do we treat this child? You can't see any deficiency? Yes. So it's correct. Diagnosis is correct. It's a short femur. So it's a congenital short femur. So 2-year-old child, would you do anything? Because the parents will bring to us, all of us, that the child is having shortening. They're 4.5 centimeters. So what should we do? For 2-year-old child, how would you treat it? That's very simple actually. We are going on different cases, but we'll discuss a few cases actually. Yes? Wait and see, yes. Anything else?
So initial deficiency is very important. What is the deficiency at birth or initial years? And from that we can project what is the amount of deficiency which is going to be in future. Secondly, one should also see here that the femoral epiphyse will not yet appear. And when it appears, the neck shaft angle may not be normal. So we need to know what is happening there. One good thing is that the acetabular radial cartilage is good. So this suggests that this will be a functioning hip joint. And we will need to assess the leg and the foot also, because we want to know if there is, along with that, if there is a tibial or fibular element in the foot. The knee, range of movement, and quadriceps. That's the last thing.
Very important points. It's very nicely mentioned. So you want to add anything? Okay, I'll not go in great detail, but that's very important points what the Dharal has mentioned. That I will go and quickly say the clinically always assess the hip deformity in all 3 planes, sagittal, coronal and horizontal. Always check about the stability of hip joint, whether the proximal femur is there or not. So DDH is different and PFFD is different, or congenital femoral deficiency is different. Always examine the knee joint, because the knee joint is real much more troubling when you do about lengthening. Because yesterday I heard that most of the here are very much interested in doing about Elizabeth reconstruction and lengthening. But the lengthening in the limb deficiency is different actually. It will be associated with multiple complications. So always assess the hip and knee stability, because if they are unstable, we will make it that worse. The person would be ambulant, will become non-ambulant. Okay, and I have actually seen that patients where lengthening in limb deficiency is one of the most dangerous actually. It's word of caution. What Taral said, that foot deformity very commonly is associated with the fibular hemimelia. PFFD is always check that with the fibula, whether the fibula A is intact or not, is it associated with the tibial shortening or not, and the foot, whether that foot is stable or not, whether it's how many rays are there, whether it's intact femur or non-ossified. Okay, I will go in more detail, because if it is not visualized, it may be not present or late ossification, or it may be pseudoarthrosis. In earlier child, it all looks same. If you see about 2 years old child or 2 months old child, it looks same. But the all would be present, because I will go into next classification. The classification describes various types, but that its type depends on the MRI. Okay, when we see about the plain X-ray, all look same. So it's like very important to say whether the hip ossification is present, whether it's a delay or pseudoarthrosis. It's very common, or intact femur. Associated deficiency of upper limb, because if it is associated deficiencies, upper limb is present, we need to do more about reconstruction rather than the ablation. Amount of shortening, what the Taral said nicely, you need to say how much is limb length discrepancy. And the most important part is that predicted limb length discrepancy at skeletal measure. Yesterday was a point of discussion was there, what you will do for 4 or 5 surgeries. This is one of the most challenging problem. Not a single PFFD case, even though it's a mildest case, will get away with very single surgery. Okay, not a single surgery. And again, we may not get exactly the similar looking leg like opposite side. So it's very important to say how much is deformity, how much is shortening, and what is it? Projected limb length discrepancy. Another important aspect, whether it's unilateral or bilateral. Though bilateral is uncommon, we can do about the bilateral deformity. What the society needs, if we read about the Rod Palais, he said he's the most experienced PFFD surgeon in the world, but there is no role of the amputation for hand. He describes the various types of the complex and complicated surgeries that most of the surgeons across the world, including the United States of America, they cannot reproduce. So what is required of the society is also very important. See, the developing country like India and Bangladesh is different than the US. So don't try to mimic exactly the same. Another last important point is the experience of the surgeon. This is not the surgery that everybody can be used to or familiar about that. Okay, that is very important. Taral, would you like to add anything? Okay, anybody wants to? These are just the facts what I am saying, that these are the assessment we need to do for the PFFD, because it's a complex issue. We come back to the different points and the classification, what this is a broad palate classification. It's actually the good comprehensive classification. He divides whether the proximal femur is present or not. It's a type 1. Type 1 is divided in, say, if it is delayed ossification, it's a 1B. 2, when there is a pseudoarthrosis will be present, but the femur is present, whether pseudoarthrosis of neck or subtrochanteric. 3rd, that is proximal femur is absent. And the 4th, it is a distal deficiency. You can make out that's 1, 2 and 3, 4. That makes some sense. But he described that some of the surgeries like super hip surgery, super knee surgery, but it's a complex surgery. And make it very simple. It's combination of soft tissue release or soft tissue contraction address, as well as the bony correction. Morning, what is common is a Coxa-Vara. What Taral has mentioned very well, the Coxa-Vara. So this classification is very, very commonly used. So somebody can say what was the our X-ray, what was the our case, what is the type? Type 1. Okay. So it's type 1 because it's intact. The femur is intact. So normally when we see about the child, we need to say that predicted limb length discrepancy for how much is for the at the skeletal maturity. It depends on that. We need to chart out the plan whether the child will require how many number of surgeries. Till then we can use with the sole raise or that extension prosthesis or you got AFO with the sole raise. That is needed in the 2-year-old child. So we waited. This is a 6-year-old child. The child was walking with the extension prosthesis. Then he said it's a correct age, it required the 2 surgeries. One surgery is we do to the lengthening because hip and knee was stable and he's got a good region width. The child has been followed up to the 9 years. We say the limb length discrepancy is there. That time we addressed with the opposite epiphysiodesis. And at the maturity, the child is almost skeletally mature, is walking very well. That is, you can't make out that's. And the limb is quite aligned. This is one case. Any question, any doubt, anything? No, that's the joint. Great. Huh? This one. Oh, that is DT tube. That's great. That's a drain tube. Yes. Nothing was done for the proximal. It's nothing for it. Yeah, we used to put up a drain. Long back we used to have that drain for the after doing for the surgery and the osteotomy. I need. Join. Is it audible? We got to 6 centimeter pairs.
When is the ideal time?
What is ideal time? Depends on the child's age and predicted limb length discrepancy. Suppose there is more than 3 lengthening is required, we can do 6, 9 and 12. If it is there more than that, we can start as early as 4. We should not lengthen, we cannot, that is reason I like to wait because we cannot lengthen more than 20% of original length. It will be associated, more than 50% will always associated with the complications. And believe that the congenital short femur lengthening may associated with dislocation of hip as well as dislocation of knee. And I have corrected also. I'm sure the Taral would have also corrected that. It is much more difficult. So prevention is better than cure. Please remember that. PFD is not very easy, not very straightforward. So lengthening, word of caution, be slow, check about soft tissue contracture, get the good help of the exercise, do about that. If its deformity happens, stop it. Okay, you plan for the 5 to 6 centimeter, but if 4 centimeter, if deformity happens, stop it. I think, okay, is it? Okay, I'll go on second case. Yeah, anybody can say, is again the same thing is written. What is the classification? Like to say anything? 1B. Sir, do you want to say 1B or is it 2? Okay, sir? 2, okay. Taral?
Telescoping test. And if it's not telescoping, it is what? Telescoping, if there is no telescope.
Yeah. Actually, the drawer Pele uses, as I said in beginning, it's very difficult. It's correct. We'll say 1B or a 2A, 2AB, and I said clinically telescopic on that, but it's again subjective. If you want to do the confirm, we can do about MRI. Why MRI is not required? Because you are not going to treat the patient at presentation, so you can follow up also. Second part is there, MRI will require anesthesia sometimes in very young child or sedation. So practical things, so you can wait. Wait. 4-year-old child. Now? Is it 1B? Again, we can't say whether it's delayed ossification or pseudarthrosis. If it's delayed ossification or pseudarthrosis. So it's the simplest way you can get adduction and abduction view. It's a non-union, it's mobile non-union, it will move. If it is stiff non-union, it will not still move. Okay, it's a very practical things. I'm just saying that you can do about adduction and abduction X-rays, and that's the abduction and adduction X-rays. And it used to see about moving. You can say about adduction and abduction X-rays. It's moving. It's
Type 2.
so type 2. So it's
2A.
so yeah 2A. So actually the palette describes the super hip surgery, but I will say in a brief what is the surgery in super hip. We need to do about the correction of the coxa vara. We need to do about the soft tissue contraction, which is a flexion deformity. Then you need to do adduction contraction release and external rotator, and do about the valgus osteotomy. So and whenever we do about the valgus osteotomy, we'll make the hip into the unstable. So always address the acetabulum at the same time. So we can do about the Degas osteotomy. We can do about the lateralization of it. I think Taral is going to talk on the correction of the coxa vara, but same principle we can use in that. Only here difference is there. We are addressing also a non-union. So we need to gain that non-union. It's not only the plain coxa vara. If it is delayed ossification, it's okay, but you have to keep this in mind. Many people will inject the BMP. Many people, that's original palette described the injecting BMP because it will help to our union. If the neck is okay, we can use about the fibula graft also. If it is there, we can use about that for the fibula graft. This particular case, it was not used, but valgus, the correction was done. What will happen if it is the neck doesn't unite? It will recur. And I was discussing that if it is possible, then you have to keep the child in follow-up. You have to keep the child in follow-up, and if you chance it's recur, you have to redo surgery. That's very important. But unless you do correct the coxa vara, unless the knee stability you gain it, don't try to do about lengthening in this child. So the child has been done valgus osteotomy and neck was stable, it's fine. We followed. We can see that neck is forming, but again, its child was due. We did about lengthening. We retained the screw, and that's lengthening. It's got the good lengthening, but that's regenerate has got little bit bone. And we can see the photograph child used to walk with the extension prosthesis. Used to walk in the extension prosthesis. Later we see that still not happy. Let's take about adduction X-ray and see that the coxa vara is recurring. So we did the coxa vara correction. This is another way. It's a very simple way what the Frazier described for the coxa vara correction in osteopenic condition, because we want to do the lateralization. What the Taral used to show is that how is the proximal fragment is adducted. That's actually used. It's showing in the coxa vara the top, but that's the coxa vara got corrected. Then later we did about opposite epiphysiodesis, that is a fourth surgery. And the fifth surgery we again corrected little translation on the lateral part and did the lengthening. And this is the child has a 15 years follow-up. He's walking with reasonably well. He will require more lengthening. Yes. Any question, any doubt, Sarwar, anything? Any comments, anything? This 15 years, child is okay, independent walking, he will require one more surgery, one more. Next up angle is around 100, but it has to go 120, but along with that, I think I need to do, if I will correct that, I will require about PO. So it's a coxa vara is a boon for the stability.
So what one should do, if you are doing lengthening, one more lengthening, if the neck shaft angle is corrected and if it is unstable, it will dislocate. So let the neck be in valgus. You finish on the lengthening and at the end correct the valgus. Okay, and when you correct the valgus,
this varus is good. Varus is good.
Correct the valgus, and when you correct the varus, you will end up uncovering the head. So that time you will have to also add the established procedure. So keep the hip final tuning at the end after you finish it.
I think I'm going to do one more lengthening. I'm not going to correct Coxavara. If I'm going to do Coxavara, I have to do PF. That's a plan. That's actually the plan for this child. But I think they will be not ready for that surgery because they are undergone already 5 surgeries. If I correct the Coxavara, yes, then I have to do it. If I don't correct the Coxavara, it doesn't do. Yes, both, yes, once.
No,
It's dangerous. It's dangerous. It's dangerous.
because it will lead to hip dislocation. It will make the hip
It's dangerous. Please don't do that. Please.
So if you are doing lengthening, don't correct Coxavara. Whenever you are correcting Coxavara, also give coverage from the acetabular side.
Yeah, third case. Yes, sir. Sarwar, what is the type? They will have one more.
The femoral head. So femoral head. So maybe.
Yeah, and why I kept this case because in initial X-ray everything looks like this. Everything looks like this. Actually, he's correct, you are correct, everybody is correct. It may be 1, it may be 2, it may be 3. Okay, so we need to wait. We need to wait. We need to wait. But this child, particularly waited, and it comes like this. What is that? At 1.5 years. Yes, but is it the? Can you see here? Next up angle is what? It's reverse. Yes, and it's shorting. That's yes. It's case of PFFD. Yes, but then it's having severe external rotation. It's severe external rotation. It's one of the excessive case of the retroversion. So such case, even though you do reconstruction or salvage or whatever you would say, for extension prosthesis, this is not going to use it. So you have to do about the rotation osteotomy and you have to correct this retroversion. And this is some perioperative range. You can see that it's retroversion and it's got corrected. Ensure that it's
Everybody can see there is excessive inferior angulation.
yeah.
And on AP view, you cannot see this.
Yes. So this is the surgery is needed even for the extension prosthesis fitting. It's surgery is needed for the whether you do reconstruction or salvage. So these are the supplementary surgery for the even prosthesis. Yes, child underwent the external rotation and this is the final follow-up. You can see the pre-op X-ray and the post-op X-ray. And then finally the child is straight and you can see that neck shaft is there. It's like it's type 1. Okay, so now you can see about the child's whether you do the reconstruction or the extension prosthesis, whatever is there. The next case, what is this type?